So this is number 3 in the lecture series of heart failure. So in this section, we're looking at the initial and serial evaluation of heart failure patients. So when someone with shortness of breath comes to see you, and what you're going to do. So just like anything else in medicine, we do a detailed history, and we do physical examination. Is sort of examination that looking at why the patient is short of breath. So H&P is the cornerstone in the assessment of heart failure patients. Just like anything else in medicine, you can make your diagnosis from history and physical examination. About up to 80% of your diagnosis can be made just on H&P alone. So detailed physical history and physical examination. So you have to know what type of questions to ask. Someone comes with shortness of breath. So again, it's a class 1 indication. A thorough history and physical examination should be obtained and performed in patients presented with heart failure to identify cardiac and non-cardiac disorders or behavior that might cause or accelerate development of progressive heart failure. It's also recommended that you do a 3-generational family history, because sometimes as we looked at heart failure, we show that one of the cause is a familial dilated cardiomyopathy. So you have to find out if any other family member had heart failure. The volume, status, and vital signs should be assessed at each patient encounter. So you have to sort of go over a mini history when the patient comes back. And of course, in your assessment, you're going to do serial weight assessment, as well as you're going to look at the jugular venous pressure and look for signs of peripheral edema. People who are doing exams, again, you'll encounter one of the things that they'll ask you is what is the best method of assessing volume status, and of course it's a jugular venous pressure. Okay, so other things that you can use to assess volume status is ascites, edema, but one of the most accurate is the jugular venous evaluation. So the history will provide clues to the etiology, the cause of the heart failure. As we mentioned before, you have familial cardiomyopathy, and you need to do sort of generational history. That is, if 2 or more relatives had idiopathic dilated cardiomyopathy, you might be dealing with a familial cardiomyopathy. Again, 20 to 35% of patients with idiopathic dilated cardiomyopathy have a familial cardiomyopathy. So again, the 3-generational history should be obtained. The history is also going to give you information on the severity of the disease. It will give you some insight into the prognosis and the opportunity for therapeutic intervention. So, when you're doing your history, you have to get a lot of information about the shortness of breath, when the shortness of breath started, weeks, months, whenever. Shortness of breath with exertion. What kind of exertion? Is it regular activity, or is it just with extreme activity? Does the patient have orthopnea? They can't lie flat in bed. They have to prop themselves up. They sleep in the recliner. Do they have PND? Go to bed, fall asleep, and have to sit up, jump up out of bed to breathe. And then the physical examination, you can also get information on the severity of the illness, because examine the patient jugular venous pulses, right up to their ears, RAS all over the place. And so again, you can get information on the volume status and the adequacy of perfusion. The extremity is extremely cool, then you know that the cardiac output is reduced. So again, a careful family history may identify underlying familial cardiomyopathy. So do your generational history. You can also get information on duration of the illness, how long you've been having the shortness of breath, or were you diagnosed with, the patient may tell you, I was diagnosed 5 years ago with heart failure with reduced ejection fraction. So, get that good history. Severity and triggers of shortness of breath and fatigue. Look for the presence of chest pain, exercise capacity, physical activity, sexual activity. If they have severe symptoms with regular activity, then we talk about the class of heart failure. So they may be a class 2 or 3. So you really have to get the history clear. Anorexia, early satiety. I mean, they have no appetite. They get full easily. Weight loss. So remember, GI symptoms, gastrointestinal symptoms are fairly common in patients with heart failure because the bowels can get congested as well, and they don't absorb or they feel full. Cardiac cachexia, I mean, wasting away, and that is associated with very bad prognosis. Patients usually don't do well once they start developing cardiac cachexia. Weight gain. So remember, that is how we do our evaluation of these patients when they come to see us. Every time they come to see us, we have to do weight because it's one of the more or one of the most accurate means of assessing volume status. Uh, rapid weight gain such as volume overload, palpitation. So you're gonna patient have palpitation, heart fluttering, heart racing, feel faint. If they have a ICD in place, they get a shock. So palpitation is going to tell you whether the patient's having some type of arrhythmia, and a fairly common arrhythmia in dilated cardiomyopathy is atrial fibrillation. So they may have atrial fibrillation. They may even have ventricular tachycardia. If they tell you they have ICD shocks, it may be a ventricular tachycardic episode that they got shot. So that history is going to be key. So you have to know you have to know the questions to ask them. Again, in the physical examination, you're going to look for signs of edema. If the patient is in bed all the time, you'll get that swelling in the sacral area. You might get even leg edema. What about disordered breathing at night? So remember, sleep apnea is fairly common in patients with heart failure. So, you might get a history of the patient stop breathing in the night or snoring quite a bit. And heart failure, these patients tend to get admitted quite often. Remember, you have 25% readmission in the first month. So, and that's associated with an adverse outcome. So, you guys try to mute your mic so that we don't get any background noise. Okay, please. Okay. In the history, also, you need to, is the patient taking the medicine? Because you might be prescribing all the right medicines and stuff like that, and then you find out the patient is not taking the medicine, or they may be intolerant to the medication. and stuff. So a lot of patients, they'll have problem with the medicine, just stop taking it, and then they come back and you think they're taking it. Um, Also, they may be taking other medications which can aggravate heart failure. And one of the common medicines that can do that is NSAIDs, non-steroidals. Um, Also, dietary history is important because remember, we put these patients on salt restriction, and some of these patients also fluid restriction. So they may be eating a lot of salty stuff and drinking a lot of fluids. Um, Again, with the physical examination, when the patient comes to you, you can do the BMI. Okay, all you need to do the BMI is the weight and the height, and then of course you're going to follow serial weight. You need blood pressure. You can do blood pressure both supine and upright. See if the patient is orthostatic, especially with older patients. And again, the jugular venous pressure at rest is one of the most useful findings on physical examination to adjust to identify congestion, and that's an exam question. Okay, if people do an exam, it is the most useful finding to identify congestion. So make sure you do look for your JVD. The presence of extra heart sounds and murmurs. So again, S3 is associated with adverse prognosis in patients with heart failure with reduced ejection fraction. So the important thing here is good history and a good physical examination. As a matter of fact, if you can do a good history and physical examination, you can diagnose heart failure in probably 95% of the cases, okay? Look for evidence of hepatomegaly if they have had heart failure for a little time. It's another sign of volume overload. The liver will be enlarged, and sometimes you get a tender hepatomegaly because the liver capsule is stretched, and when you palpate the liver, it will be tender and enlarged. Look for ascites as well, peripheral edema, and then if the lower extremities are cool, they may be dusky, um, which suggests a reduced cardiac output. So the important thing, good history. When someone come to me with shortness of breath, I spend at least just 10 minutes talking about the shortness of breath because that is how I make the diagnosis. So patient comes to you, you take your detailed history and your physical examination. You can do what we call a risk scoring. That is, you can determine how sick the patient is and see how well they're gonna do. And we do that by doing risk scoring. So the potential risk for adverse outcomes, so that is what the information we're going to glean from this, the potential risk for adverse outcome, and it may help us also in therapeutic decision, what kind of medicine, what kind of therapy you should put this patient on. And it may also uh, give you information on the rapid transition to advanced heart failure. So what are the methods we use to risk score these patients? Again, remember when we say risk score, we're going to see how sick these patients are and how well they're going to do. So we have a number of multivariate clinical risk scores, and we're going to discuss those. You can use a risk score if the patient is an ambulatory patient, patients come into the office, or if the patient is a hospitalized patient. We also use biomarkers to see how sick the patients are as well. So the multi the multivariate risk scores can be useful to estimate subsequent risk of mortality in ambulatory or hospitalized patients. So it only gets a class 2A indication. So you don't really have to do it, but if you can do it, you probably should because it It helps you to determine, how sick the patients are, and how well they're going to do. So these are some of the risk scores. We have the Seattle heart failure model. We have the heart failure survival score, the CHARM risk score, the Corona risk score, iPreserve score, uh, and those are for chronic heart failure with preserved ejection fraction. I mean, the ones before were chronic heart failure with reduced ejection fraction. So the Seattle, the CHARM, and the Corona. For patients with preserved ejection fraction, you use the high score, the iPreserve score. And then for acutely decompensated patients, that is patients in the hospital, you use the Hader classification and regression tree chart model. And the American Heart Association guidelines, you can use that. But basically, we only use about two of these risk scoring methods. The Seattle heart failure model, we use this for ambulatory patients. So patients who comes to the office and see you, we can use the Seattle heart failure model. So it's an online application and you don't have to memorize anything. You basically, the patient comes to the office and you just go online, you plug in the data, and it will give you the risk of mortality, the risk of mortality in these patients. So it's an online application, and you don't have to memorize anything. Just go online, put in each patient information. Now the Harrier score is for hospitalized patients, and that's the acute decompensated heart failure national registry. And again, it's hospitalized acute decompensated heart failure patients. You need three variables: the systolic blood pressure, the BUN, and the creatinine. And again, you can go online and you get your risk score, the risk of the patient dying. Okay, so class 1 indication for initial and serial evaluation. When the patient comes to you with shortness of breath and you do your history and physical examination and you determine that this may be heart failure, then you want to do some blood tests. You do your complete blood count, CBC. You want to do urinalysis. Okay, complete blood count. You want to see, is the patient anemic? Because if the patient has something like any chronic disease process, they may be anemic, or sometimes the anemia, severe anemia, can give you heart failure. So you want to complete blood count, urinalysis. Do they have any infection? Do they have renal compromise? Serum electrolytes, and that should include calcium and magnesium. Okay, you will miss a lot of stuff if you don't do these very basic tests, but you have to do them. Again, the BUN and creatinine, looking at the kidney functions, glucose. Patient may have diabetes, fasting lipid profile, liver function test, TSH. Remember, we had talked about hypo and hyperthyroidism, and you can do serial electrolytes and renal function, depend on the situation. Especially if you put them on a medication that the dosing depends on the renal function, because some of these patients, when you dry them out, the renal function gets bad, and you have to adjust your medicines or stop the medication completely. So you can't just leave them on the medicine and just forget about them. You have to look at the renal function, electrolytes. Some of the medicine can cause severe potassium depletion, and a low potassium can cause a lot of problems. So you need to check your potassium. 12 lead should be done on all patients who present with heart failure. So again, So these are tests that you should do, and depend on the situation, you might want to screen for hemochromatosis. Remember that was one of the cause for heart failure, or you may have to look at the patient HIV status. You know, so depending on, so you're gonna get all of these information from the history, and the history will sort of guide you as to what tests. But the tests that were mentioned before, these are, everybody get these tests, and then you might wanna, depending what you got from the history and physical, you might want to do a screening for hemochromatosis, iron overload, or HIV, or you might want to do diagnostic rheumatologic assessment. You may want to look for amyloidosis, pheochromocytosis, or something like that. But the history and physical will guide you in that direction. Class 1 indication, so you suspect heart failure, you want to do a BNP, and you may want to do just a regular BNP, or you may want to do an N-terminal BNP, okay? N-terminal pro-BNP, or NT-pro-BNP. So you can do either of these. So, but you have to do a BNP level. It can be just a straightforward BNP, or it could be the NT-pro-BNP. It will help you to support the diagnosis of heart failure. Again, don't forsake the history and physical, and the patient I'm shortness of breath, you do a BNP. No. You're gonna mess up the patient in a lot of time. Heart failure is not the only thing that can cause an elevated BNP, and you can have heart failure without elevated BNP. So never do that. Never do that. Okay, you will run into a lot of problems. So do your detailed history and physical, then you do your BNP. It is supportive. It's not going to make the diagnosis. It will be supportive, especially if you're not sure what's going on. Again, measurement of the BNP, or the NT-proBNP, is useful for establishing prognosis. So it gives you prognostic information, and it can also tell you something about disease severity in chronic heart failure. And I will mention, when to do the BNP or the NT-proBNP. Well, let me mention it now. If the patient is taking neprilysin inhibitor, you don't want to do a BNP. You do an NT-proBNP, and I'll explain, what we mean by that further. But if the patient is taking and neprilysin inhibiting medicine, then you do an NT-proBNP. So class 2 indication, you do the BNP or the NT-proBNP to help you to make the assessment. You can also use it to guide therapy, because once you treat the patient aggressively, the level should start to fall. I don't do it, but if you want to do it, that's fine. They're not going to test you on that. So you usually get test on a class 1 indication, which it's supportive, help you to make the assessment. Class 2B indication, you can do serial measurements, and it give you information, and if the patient is going to need to be rehospitalized. Because if you have say a BNP level of 4,000, and you treat the patient, and before you send the patient home, the BNP is still 3,000 plus, the likelihood of that patient coming back for admission is great. And the likelihood of the patient dying also is great, because it's a very elevated BNP. You can also we have other markers. So the BNP and the NT-proBNP is not the only markers that we use, not the only biomarkers. So we have other biomarkers that will look at myocardial injury, the troponins, or myocardial fibrosis, the ST2 and the galectin 3 um, um, uh, factors. So you can do those as well. But in clinical medicine, we use mainly BNP or NT-proBNP. All right. So, you know, people doing exams, they like to ask you about biomarkers. So you have to know a little bit about the biomarkers. So they reflect various pathophysiological aspects of heart failure, such as wall stress. Okay, so the BNP is one of those biomarkers that is produced when the heart is you have wall stress. Hemodynamic abnormality can also give you some biomarkers. Inflammation, myocyte injury, neurohormonal upregulation, myocardial remodeling, and extracellular matrix turnover. So when the heart muscle is stretched from whatever cause, pro-BNP is released, and the pro-BNP is broken down into BNP and NT-proBNP. Now, the neprilysin inhibiting medication or drugs, it's gonna block these biomarkers coming from pro-BNP are gonna be broken down. The BNP is broken down by neprilysin, and the neprilysin inhibiting drugs is gonna cause an accumulation of BNP. It's not gonna affect the slim of the byproduct. So if you're taking one of the neprilysin inhibiting drugs, you're going to get an elevated BNP. So you can't use the BNP in that situation to evaluate your heart failure patient. Again, myocardial stretch will give you pro-BNP, and then your pro-BNP is going to be broken down into BNP and your NT-proBNP. The BNP or the NT-proBNP is going to establish the presence and severity of the heart failure. And again, if your heart failure or your shortness of breath is not you're not sure what's causing the shortness of breath, then the BNP becomes important. So some of the cardiac causes for elevated BNP, heart failure, of course, anything that includes RV syndrome, acute coronary syndrome, heart muscle disease. Any type of heart muscle disease includes left ventricular hypertrophy, valvular heart disease, pericardial disease, atrial fibrillation can do it, myocarditis, cardiac surgery, cardioversion. So these are all things that can give rise to elevated BNP. So elevated BNP doesn't always mean heart failure. There are other things that can do it. And then there are some non-cardiac causes, advance in age. So the older one gets, the BNP will be a bit higher. If the patient is anemic, renal failure, pulmonary disease, obstructive sleep apnea, severe pneumonia, pulmonary hypertension, and any type of critical illness. Patient is very sick for whatever reason, bacterial sepsis, severe burns, toxic metabolic insults, including cancer, chemotherapy, and the environmentation. So there's a lot of things that can give elevated BNP. So that shouldn't be the first thing you do. The first thing you should do is a thorough history and physical examination. So again, myocardial stretch, you get increased proBNP, broken down into BNP and NT-proBNP. So then the levels should improve with treatment, and they should get lower over time. If after you treat these patients aggressively, if the level is not falling, then that may be a risk for death or hospitalization. So the patient may need to be admitted to the hospital, or it's an indication of death. So another biomarker comes from myocardial injury, damage to the heart muscle cells. When the heart muscle cells are damaged, you're going to release either troponin T or troponin I, and we can measure that. So we measure that in the blood. In heart failure, we get elevated troponin T or troponin I. Not very high, but we do get some amount of elevation. And we get these elevation without the patient having any significant coronary artery disease or ischemia. Okay, so sometimes just the increase wall stress can increase the troponins. Also, it may be a sign of myocardial injury necrosis. That is, the heart muscle cells are being damaged continuously. In chronic heart failure, elevated troponins suggest impaired hemodynamics, progressive LV dysfunction, and it also tells us about increased mortality. Patients don't do very well. So if the patients have a chronic elevated troponin, these patients, they're probably not going to do very well. In acute decompensated heart failure, elevated troponin may mean that the patient can have an acute coronary syndrome. So you always remember that. Patient may be having a heart attack, but if they're not having a heart attack, it may suggest a worse clinical outcome, increased death, and you should do troponins routinely in these patients, okay? And then the biomarkers for myocardial fibrosis is the ST2 and galectin-3. Clinically, we don't do a lot of these, but they're there. All right, so the recommendations for biomarkers in heart failure, okay? Again, class 1, patient comes with shortness of breath, it is a class 1 indication, okay? So whether the patient is ambulatory or the patient is admitted, class 1. Whether you're going to use it to follow the patient now, it may be a class 2A or a class 2B, but to help you to make the assessment of heart failure, it's a class 1 indication. Shortness of breath, you do your history and physical, and even if you're not even if you're sure that is heart failure, you can do a BNP level, because the higher the level, gives you information in terms of mortality. Initial and serial evaluation, you want to do some imaging. Okay, you want to do some imaging. All patients with first-time heart failure should get a chest X-ray. All patients with first-time heart failure should get an echo. You can do radionuclide studies. You can do MRI or CT, or you may want to do a myocardial perfusion scan. But your chest X-ray is a class 1 indication. Patients with heart failure supposed to get a chest X-ray. Okay, patients with heart failure should get an echo. They should get an echo. Okay, and if you're treating these patients and they're getting worse, you need to get a repeat echo. If you put them on a medication and they're improving, and you want to assess because they're doing so well, that's also an indication for echo. Um, what you don't want to do is just routine repeat measurements of LV function every time the patient comes or whatever for no good reason. You don't do that. So the repeat echo have to be indicated. So patients with suspected or new heart failure or those presenting with acute decompensated heart failure, they should have a chest X-ray. You want to look at the heart size, you see if there's pulmonary congestion. There may be, the patient may have a pneumonia. So, the shortness of breath may be due to pneumonia. So you want to look for that. Um, your two-dimensional echo with Doppler should be done during the initial evaluation. Okay. You want to look at the ventricular function, ejection fraction, diastolic function, the size, wall thickness, wall motion, and valve function. Repeat echo now. So repeat measurement of EF and measurement of the severity of structural remodeling are useful. Okay, so you can do that. However, if there was a significant change in the patient clinical status, then you can do the echo. Um, Patients who have experienced or recovered from a clinical event uh, or who have received some sort of treatment, you want to do your repeat echo. So the repeat echo have to have a good reason. So it shouldn't be just routine. So class 2A, you can do other non-invasive imaging to look for myocardial ischemia and viability. So, you may want to do a myocardial perfusion scan if you suspect that the patient have coronary artery disease. If the patient you suspect that the patient have any type of blockage, you may want to do a test to look for that. Viability studies. So if the patient have an ejection fraction of 20%, you want to know if there is any viable muscle there. Because if they're viable muscle, then the patient may be a candidate for revascularization. That is, you may want to do stent or bypass surgery. Your radionuclide ventriculography or magnetic resonance imaging. If your echo cannot give you adequate information in terms of ejection fraction, you may want to refer to one of these studies, the radionuclide ventriculography or the MRI. So they're very good. And then your MRI, if you suspect myocarditis, then this is the test to get. If you suspect sarcoidosis, then this is the test to get. So the other imaging modality, depending on what your suspicions are. So you should not do repeated echoes just because it's routine for the assessment of LV function. So you have to have a good indication. And I think, well, probably for cardiology fellows, but general medical doctors need to know this as well. So you can see something like this on your test. They don't want you to get unnecessary tests. So if the patient is getting worse, you're treating the patient for heart failure and they're not improving, they're getting worse, then that's the time you send them for another echo. If you put them on medication and you want to see the effect of the medicine, then um, you know what I do sometimes is um, you know if you have the patient a guideline guideline directed medical therapy, maybe a beta blocker, aldactone, um, Entresto. So Entresto is a new medicine with the neprilysin HARB combination, the valsartan, and that is fairly a very good medicine. So after having the patient on that medicine for like 3 to 6 months, I would repeat they echo to see if the ejection fraction uh, improve, and it in a lot of patients it does improve. So let's stop here, and then our next session we will look a little bit more into some of the imaging. But we're gonna stop here, and on Thursday we will continue with a little bit more information on heart failure. And then once we give you all the background information, then we'll go into therapy, how you treat these patients. Well, you have to know what you're treating, and how to treat them before you start embarking in therapy.